Good evening, everybody, and welcome to the webinar, Fundamentals of CBCT Imaging, Anatomy and Anatomical Variations. I would like to thank Dexus and Viva Learning for inviting me to speak with you this evening. I'm Lisa Koenig, and I have spent the majority of my academic career at Marquette University School of Dentistry in Milwaukee, Wisconsin. But as you can probably hear, I do have a little bit of an accent still because I was born in England in a little place called Fleetwood on the West Coast. And I went to dental school in Leeds. If you know a little bit of the history of United Kingdom, you know that Lancashire and Yorkshire were in the Wars of the Roses. So I grew up in Lancashire, but I went to dental school in Yorkshire. I did practice dentistry for a few years in England and then came to the United States, where they did not recognize my dental degree, so I went back to dental school. I started teaching full-time in 1989 in the radiology department, and I did my advanced degree in radiology in the early 1990s and was boarded in oral maxillofacial radiology in 1996. But as I said, I spent the majority of my time teaching radiology at the dental school at Marquette. For the last few years, I was the associate dean also for academic affairs. So here's the course outline. We're going to talk a little bit about CBCT, an introduction to the fundamentals. We'll talk about radiation dose and compare it to some other imaging modalities. And then we'll look at some anatomy and anatomical variations. This is my disclaimer. This course is intended for licensed dental professionals. The views and opinions expressed are my own and do not necessarily represent the views of Dexus. I am compensated for my time to lecture. However, I have no financial interests in Dexus or Viva Learning for that matter. And the course objectives obviously follow that. We want you to be able to understand the basic concepts and recognize anatomy on CBCT images. So why is it called cone beam? It's called cone beam because it has a cone-shaped X-ray beam, which you can see on the right side of the screen here, which is different than medical CT, which uses a fan-shaped X-ray beam. And also, unlike medical CT, for those of you who've had a medical CT, you'll know that you're lying in the gantry and the gantry actually moves as the X-ray beam moves around you. But in cone beam CT, the patient is stationary as the X-ray beam moves around. So here's a typical CBCT machine. It looks very pan-like. It rotates around the patient's head, very similar to a panoramic machine. However, it's doing different things and it's acquiring the images differently. But with any of these image acquisition machines, we always have to have an X-ray source and we have to have an X-ray detector. So the detector is going to detect the remnant radiation that comes through the patient. And as the machine rotates around the patient's head, it's acquiring a whole series of what we call basis images. And those basis images are basically two-dimensional images, which after the rotation has stopped and we release the X-ray button, the computer then uses its algorithms to take those images and form a volume. So once the rotation stopped, the computer reconstructs all of these images and gives us a volume. So the reconstruction time is the time it takes for the images to come up on the monitor after the rotation has stopped. It depends very much on the resolution of the scan, the voxel size, and the number of projections. So what do we mean when we talk about voxels? Well, voxels are three-dimensional, or what we call volume elements. Everybody's heard of pixels. They're two-dimensional or picture elements. In CBCT imaging, it's important to recognize that the voxels are isotropic, which means they're equal in all dimensions, which is a little different than medical CT imaging, where the voxels are actually more rectangular. So when you think about voxels in a CBCT volume, think about Rubik's Cube. So the Rubik's Cube as a whole is a cube, but it's made up of little individual cubes, which makes up the whole volume. But in CBCT imaging, unlike the Rubik's Cube, we can't give more than one value to the cube. So in this instance, we've got different colors on the cube, but in CBCT imaging, the cube can only have one value. So if we kind of superimpose a matrix over the patient's head, you'll see these little cubes represent individual areas or tissues within the patient's head. And through the wonders of the algorithms, the computer is able to work out what the density of each one of those little cubes represents. So if it's a little cube sitting in the maxillary sinus, the computer recognizes that is a low density area. It is air-filled. And so it assigns it a corresponding value from black to white and all the different shades of gray in between. So a maxillary sinus would be a very dark shade of gray or even black. And so when we see the CBCT volume, it's a compilation of all of these different cubes, which in turn relates to what we call the attenuation coefficient of the tissues. So in other words, how do the tissues attenuate the X-ray beam, or how dense they are? So voxels are important when we think about the resolution in the scan. The number and the size are very, very important. So if you look at the teapot in the foreground here, you'll see that the teapot is very voxelated, if you will. The voxels are very, very big. We don't have very many of them. In order to get a very, very smooth, high resolution image, we're going to need to have way, way more voxels and much smaller voxels. But as we decrease the size of the voxels and increase the number, we need to have more projections and we need to have more data for the computer to analyze. So usually the acquisition time is longer and the size of the volume or the size of the image data is greater. So after we've done our reconstruction, what happens is the computer then displays the image. And I am going to just pause this for just a moment because I just want to explain what's going to happen here. So this is a typical presentation screen for any CBCT machine. You're going to get what's called an axial, sagittal, and a coronal view, and sometimes you'll get a 3D, if an optional view down in the lower right here. So when you look at these views, you can either put your mouse over the view and use your rollerball to scroll through them, or you can use these lines which are on the images here. So this line, the orange line, represents the axial view, and as we move that orange line up and down, we're going to go from the top of the head to the inferior border of the mandible, and we're going to go in an up and down. So axial views slice the patient in an up and down manner. This view here is actually the sagittal view, and you can see that this slice here is basically just about midline, right? And if we're going to slice, we're going to use this and we're going to scroll back and forwards. We're obviously going to go from one side of the patient's face to the other side, so from one temporomandibular joint to the other. And then finally, this purple line here represents this image right here. So this is the coronal view, which slices our patients back to front. And so we're going to go to the front of the nose, and then we're going to go all the way back to the cervical spine. Now, this is a very, very big field of view, but I think it helps for you to understand exactly what is happening in these slices. So let's run the video, and you can see we're going up and down in the axial view, top of the head, down to the inferior border of the mandible and back. Now we're going to do the sagittal view, so we're going to go to the left temporomandibular joint, all the way through mid-sagittal plane to the right temporomandibular joint, and back to the middle. And now we'll do the coronal. We're going to go all the way to the front of the face, the tip of the nose, and all the way back to the cervical spine and back to the middle. So these are the typical views that we use, and it's important that we understand this terminology. But whenever I was doing CBCT imaging, I had lots of patients referred. I would always try to show them the three-dimensional image because it's a little bit easier for them to understand, don't you think? Yeah, I think so too. So it is very cool, and patients are able to understand things better in 3D than obviously looking at those axial, sagittal, and coronal images. So if it's really cool, why don't we do it on every patient? Well, we have to be aware of radiation exposure. What we need to do is ask ourselves, will it make a difference to my patient's treatment or outcomes? What is my ROI? Not my return on my investment, but my return on irradiation. Do I really need this to get the diagnostic information that I require? And you will be able to see that in actual fact, in a lot of times, yes, you do. But before we start talking about radiation dose, let's talk a little bit about radiation exposure in daily life, because we are all exposed to radiation, just living and breathing on planet Earth. And the majority of the exposure is natural background radiation. Some of it coming from the sky, cosmic, from the Earth, terrestrial, from internal, because we eat things that are grown in the Earth, and then from radon. This by far the majority is from radon, which is a gas and can be found sometimes in basements, which is why we have radon detectors. The medical imaging makes up the most of the man-made, which is actually just a small portion of the whole of the background radiation dose that we have. So when we think about radiation exposure in daily life, the average annual effective dose in the US is 3 millisieverts, or about 300 millirams. And I'm not going to go into the translation between millisieverts and millirams, but suffice it to say that this is approximately 8.5 microsieverts a day. Most of the time when we talk about effective dose, we talk about it in terms of sieverts, and particularly microsieverts, which is 10 to the minus 6, because the doses, particularly in dental radiology, are quite small. And this is a fun slide that I just put in there. Obviously, there's no peer review of this. This is the banana equivalent dose, just to tell you that sometimes the things we eat may have a natural source of radioactive isotopes, like banana. It's equivalent to 0.1 microsieverts. And so you could actually kill yourself by eating bananas if you could eat 100 million bananas at one time. That's the fatal dose of bananas. But back to the serious things of effective doses measured in microsieverts, as I said. And that effective dose takes into account the amount of radiation that we have, the type of radiation, because not all radiations are created equal, and then the type of tissue that the radiation is affecting, because each tissue type has its own sensitivity and hence weighting factor. And the weighting factors are produced by the ICRP, the International Commission on Radiologic Protection. So for instance, the lens of the eye is going to be way more sensitive to radiation than the muscle, the buccinator muscle. So they all have different weighting factors. So when we look at some of these studies that we've done on effective dose of CBCT, you'll see that they're in microsieverts. And this was an early article that was written by John Ludlow. John Ludlow is a colleague of mine. He's what I call an equal opportunity dosimetrist. He's from North Carolina. And so you can be sure if he's written an article, you know that it's been done really, really well, and you can rely on the outcomes. So there's a lot of numbers in this slide here. So let's just pick out a couple of things that blow them up so we can see. This article was comparing several CBCT machines with a 64 slice medical CT machine. And so if we look at the classic ICAT, we can see it was 69 microsieverts. The Somaton 64, the multi-detector CT was 860. So it was an order of magnitude least greater than the medium field of view CBCT. However, what we have to remember that in dental radiology is we're used to fairly low doses, and the average pan is about 20 microsieverts. And so we have to say to ourselves, well, am I going to get enough information out of this medium field of view CBCT to warrant the 3 times greater amount of radiation that I'm going to get from a pan? And in a lot of instances, yes, you are, because the pan is not going to give you 3-dimensional or buccal lingual dimensions of the arches. And we'll talk a little bit more about protocols in a moment. Here's another one, and basically this is the bottom line here. This was a Kodak 9500, and you can see the large field of view was 120. That's the one on the left here. And even compared to the dental CBCT on the right there, which is about 600, it's still significantly less. There's another article right here, and this one is actually a 2017 article that looked at CBCTs against a multi-slice spiral CT, medical CT, and basically their conclusion was that CBCT was preferable for the ear and dental arches due to its lower radiation dose and significantly higher spatial resolution. So CBCT has really good spatial resolution. And you might ask, well, why for the ear? Well, some of the ENTs or the otolaryngologists are looking at CBCT for imaging, particularly of their pediatric population, because if they can reduce the amount of radiation to their children, then that's all for the better, which brings me to the next slide. And this slide, this table came from the Sedentech CT project, which was a long-awaited guidelines that were coming out in 2011. And so this is one of the tables that I think was just very valuable from that document. And if you look here, what we're looking at is the risk in relation to age based on a relative risk of 1 at age 30. And if you look at the less than 10, you'll see that they're 3 times more at risk, 10 to 22 times, 20 to 31.5 times. And when you get as old as me, you're kind of almost up at the point of being at a negligible risk. The likelihood of someone in this age bracket dying from radiation exposure from a CBCT machine is actually negligible. I'm much more likely to die of something else than from radiation exposure. So it's very important to remember this when we think about the pediatric population, and particularly if you're an orthodontist, how many of these CTs, CBCTs do you actually want to take on your patient? Here's a comparative dose slide, just so you get a sense of where this is in relationship to the things that you're used to doing, like double bite wings and panoramic. So a double bite wing with PSP or F-speed film, about 5 microsieverts if you're using rectangular collimation. And a panoramic, as we mentioned already, is about an average of 20 microsieverts, or about 1 to 3 days of equivalent background radiation dose. When we look at a full mouth series, if you're using rectangular collimation, it's only 35 microsieverts. But if you switch to round collimation, look how much it jumps up, 171 microsieverts. That's 5 times the amount. Right, and when you look at the ScanAura 3D, which was the machine that they used in this particular article, this particular study, it was 45 to 47 microsieverts. Okay, so it's just a little bit more than a full mouth series of radiographs. So again, however, we got to think about our panoramic radiograph, right? It's only about 20 microsieverts, so keep that in mind. So that brings us to the point of image quality versus radiation dose. Okay, clearly it makes sense that the radiation dose should be as low as possible, optimizing its balance with image quality. And this comes from this article below, this Lubell article. But the big thing we need to remember is that image quality and dose are task dependent. So if we're going to do an endodontic survey, we really need very high image quality, which means, as I mentioned earlier, if we want a high resolution scan, we need much smaller voxel size. We need more data for the computer to look at so that it can give us that nice high resolution and we can see what we want to see. There's no point in saying, well, I only exposed my patient to 20 microsieverts if in fact you didn't get the information that you wanted, because in reality then you just wasted 20 microsieverts, right? So we have to make sure that we choose the field of view and the resolution based on the diagnostic task at hand. So imaging protocols that say that the field of view should be chosen dependent on the information required. And you've probably all remembered this from dental school. As low as reasonably achievable should always be followed, the ALARA principle. But nowadays we're talking about the ALARDA principle, as low as diagnostically acceptable. And this came from the NCRP, which goes back to the point that there's no point in reducing the amount of radiation down to a point where you're not getting the information that you require, because then you've just wasted the radiation. So we need it to be as low as diagnostically acceptable. And then this next comment is from the advisory statement from the ADA, which came out in about 2012. And again, another very, very common sense statement. Radiation dose for dental patients should be optimized to achieve the lowest practical level to address a specific clinical situation. So imaging protocols, if you're an orthodontist and you want to do a cephalometric analysis, or you're doing orthodontic surgery, you're going to require a large field of view. You absolutely need all the points. You need nasion, you need pagonium, you need the inferior border of the mandible. But if you're an orthodontist and all you really want to do is see where those maxillary impacted canines are and what they're doing to the adjacent teeth, are they resorbing the lateral incisors or not, then you just need a much smaller field of view just to be able to see those impacted canines. Endo, as we've mentioned already, needs very high resolution and small fields of view. And implants, it depends on the number and the location. Are we just doing the mandible or the maxilla? Mandible, or are we doing both the maxilla and the mandible? If we're doing temporomandibular joint imaging, we actually need a wider field of view if you want to capture both joints. Obviously, with these smaller fields of view, we can do the joints separately, but then you have two volumes. And in reality, when I'm imaging the temporomandibular joint, it's usually not only for problems with the temporomandibular joint, but it's also to look at any effect that the issue with the temporomandibular joint might be having on the maxilla and the mandible, and particularly in growth and development. So we would need a bigger field of view. And if I'm looking at pathology, I like to see both sides for comparison. I always want to be able to compare one side against the other. Okay, so here's some typical fields of view. Here's a 5 by 5 centimeter on the top left, 6 by 9, 9 by 11, 9 by 14. And these are kind of the typical fields of view that you see in a CBCT machine these days. And usually within each machine, there's a way not only to do these basic fields of view, but after you've done the scout view, you can then also kind of hone this down and change it within the scout view to determine the exact field of view that you want, to make sure that you've actually got the site that you want to image. So the smaller fields of view would be endo applications. The 6 by 9 would be for one of the arches. You would always want to have the opposing occlusion just to make sure that your implants are fitting in with your occlusal scheme. The 9 by 11 would give you both the maxilla and the mandible, and the 9 by 14 would give you that wide field of view so that you can actually see the temporomandibular joints, and you'd also get some airway in there if you were interested in airway evaluation. Voxel sizes in CBCT, particularly on this machine, range from 0.08 millimeters to 0.4 millimeters. Medical CT imaging, usually 0.4 or 0.5 millimeters. So our spatial resolution is much better than medical CT imaging. One other thing that I wanted to mention, here's some of the examples from the smaller field of view, is that many of these machines now have what we call MAR, or metal artifact reduction. And on this particular machine, it's available with all fields of view and resolutions. And you'll see in a moment what I mean by this metal artifact. And it's very helpful for particularly in endo applications when you may have a post in the canal, and that post will put off some metal artifact and make it difficult to interpret. So we have some major advantages of CBCT. We've been talking about the low radiation dose compared to medical imaging, but remember, it is higher than a 2D pan. It has great spatial resolution. And there's evidence to say that it's equivalent to medical imaging for visualizing teeth and bone. And as we saw in that earlier article, that NADI article, they said it's definitely preferable for ear and the dental arches due to its lower radiation dose and spatial resolution. However, even though medical imaging is not probably necessary for most diseases of the jaws, it does remain superior for soft tissue imaging. So when we look at the challenges of CBCT, one of the things is that we cannot characterize soft tissue findings, right? And in the early days, we couldn't barely see the soft tissue. As the machines are improving, we're starting to see some soft tissue outlines. However, we're not able to characterize the tissue. And so when if I'm reading something and I see a pathology that I think potentially is a malignancy that may have spread into the soft tissues, then it's time for me to refer to the medical college first for medical imaging. The other issues are the beam hardening of the metal artifact, which confound interpretation, and also motion artifacts. So what do I mean by this? So here's some implant beam hardening, and you can see those streaks coming across from those implants. So we're looking at two axial views here. The one on the left is a little bit higher than the one on the right. So when you're looking at implants, in CBCT, it's very, very good for localizing the implants and making sure that the implants are actually in the alveolar bone. So you can see from the image on the right, the implants are in the bone. And if we had a coronal view, we could tell and make sure that they were oriented correctly within the alveolar bone. But for us to be able to determine whether they've actually osseointegrated would be extremely difficult because of all the beam hardening artifact. The other issue is motion artifacts. So this is a bigger field of view. And when you have a bigger field of view, the acquisition time tends to be longer. If you have a longer acquisition time, sometimes it's more difficult for the patient to stay still. So that's why it's important to have things that will actually stabilize your patient. Having a head holder, something that will control the patient in the actual machine. And even though a lot of these machines now are actually stand-up machines, I would often bring a chair in for the patient if I thought the patient was going to have difficulty being able to stand and stay still. So in this particular image, if you look at the cervical spine, you can see that there's like two layers on here, and it's going along, particularly along C2. And if you look anteriorly, you'll see that there's actually what looks like a pseudo periosteal reaction. Now that means something completely different when I'm trying to interpret pathology, but this is just because there was motion in this particular scan. So here's a little quiz for you. The average daily exposure to radiation in the US is about 2.5, 4.5, 8.5, or 12.5 microsieverts. And the answer is 8.5. Excellent. And CBCT has good spatial resolution. True or false? It's definitely true. It has way better spatial resolution than medical CT imaging. Okay, so good. Let's do some anatomy now. And we're going to look either at a diagram or we're going to look at the actual skull before we go and look at what things look like on the CBCT images. So we're looking up at the base of the skull here, and you can see those greater and lesser palatine foramina coming out and onto the palate there. And then you'll see the lateral medial pterygoid plates. And over on the right side, you will see foramen ovale. It's a big oval foramen, as the name suggests, and it transmits the mandibular branch of the trigeminal nerve. Right behind it and laterally is the foramen spinosum, which actually transmits the middle meningeal artery. So when you look on the right side here, you'll see foramen rotundum, where you don't really see it very well. It's kind of hidden between that anterior clinoid process, right? But that's where the maxillary branch of the trigeminal nerve goes forward through into the pterygopalatine fossa. And then you'll see foramen ovale. This is us looking down at the skull base now, as if we were the brain sitting in the skull. And then you see foramen spinosum. So you see the lesser wing of the sphenoid, you see the anterior clinoid process, and you see the sella. Obviously, the anterior clinoid process and the sella, which is where the pituitary gland lives, are obviously very important landmarks for cephalometric analysis and orthodontists. So I just want to mention that you're going to see some graphics here, and they come courtesy of Elsevier and Amasis from my book, Diagnostic Imaging, Oral and Maxillofacial, the 2nd edition. We are in the process of writing the 3rd edition. This is not an advert for my book. It's just to tell you that I need to recognize that these are copyrighted by Elsevier and Amasis, and I'm very grateful that we're able to use these, because it was one of the wonderful things about writing the book was being able to work with these great graphic artists. So you'll see some of these graphics throughout the presentation. So what we have is the trigeminal nerve that sits right here on the lateral side of the sphenoid sinus. We don't have a lot to do with the ophthalmic branch, but we do have a lot to do with the maxillary branch and the mandibular branch. So we're going to talk about the maxillary branch first, which goes anteriorly forward through foramen rotundum. So you can see it going through the sphenoid bone, and that's the foramen rotundum, into the pterygopalatine fossa. And that's where it gives off from the ganglion, it gives off the greater and lesser palatine nerves. And then you can see the majority of the nerve actually goes forward underneath the orbit, and then actually and that's why it's called the infraorbital nerve. And then it exits at the infraorbital foramen. So the infraorbital nerve comes out onto the face. If we take a look at this image here, this graphic where we're actually sitting on the tongue and looking at the right side of the face, you can see that pterygopalatine fossa giving off those greater and lesser palatine nerves coming down towards the palate and exiting on the palate in the greater and lesser palatine foramen. So the greater nerve goes anteriorly to the hard palate and the sensory to the hard palate, and kind of joins up with the nasopalatine foramen, which transmits the nasopalatine nerve. The lesser palatine nerve goes posteriorly and is sensory to the soft palate. So what does that look like in our CBCT scan? So here's our axial view here now. We're slicing. We're pretty high up. You can see this radiolucency in the middle there. That's the sphenoid sinus. I don't believe you're able to see my cursor, which is unfortunate in here, because usually I like to point these out as we're going along. And I'm trying to see if I can find an actual pointer here. Let me see if I can find a laser pointer. Oh, there we go. Perfect. All right. So here's the sphenoid sinus here. So the trigeminal ganglion sits on either side here. And here's that foramen rotundum right there. So it's going to go forward into the pterygopalatine fossa. And here it is in the sagittal view. We're going to go anteriorly into the pterygopalatine fossa. And then here it is in the coronal view. And this is that typical view that, if you remember from your anatomy lectures, how everyone said that the sphenoid bone looks like the great horned owl. And so here's the horns, and here's the lateral pterygoid plate. We don't really see the medial here, but those were the feet. And then these little beady eyes, that's foramen rotundum. And so that's what we see them in the coronal view. So that transmits the maxillary branch of the trigeminal nerve. So coming down then would be the canal, the greater palatine canal here coming down from the fossa, which transmits that greater and lesser palatine nerve right here going to the hard palate and to the soft palate posteriorly. Here again is the greater palatine canal here, and that's in the sagittal view. And here it is in the coronal view. So we're looking again directly at the patient, and you can see the little space right in here is a little part of it right there on the right side. That is the greater palatine canal. And in the axial view, you'll see them as those small foramina in the posterior aspect of the palate. This is really hard to see, so I do have another view that's a bit of a close-up here, and you can see that there's that greater and those lesser palatine foramina. All right, so let's talk about foramen ovale. So we talked about the ophthalmic branch, the maxillary branch. This is the mandibular branch, and it drops basically right out of the skull base and gets into the masticator space. So it goes through foramen ovale, and what does that look like? Well, it basically looks like a hole in the skull base. So here it is in the axial view. You can see it nicely over here. Here it is in the sagittal view. So you can see it's just a discontinuity in the base of the skull here. And then here it is in the coronal view. So when you're looking at the patient like you're looking directly at them, we're just close to where the head of the condyle is here. We're just a little bit anteriorly on this side, and you can see part of the head of the condyle on the left side. And you'll see this opening, this basic opening in the skull base. And generally speaking, the foramen ovale is about 1 to 1.5 centimeters medial to the head of the condyle. And we'll come back to the mandibular branch in just a moment as we start scrolling down through the images. So let's look at some of these images. We're right in the mid-sagittal plane here, as you can see by this line right in here. So let's look at some of these anatomical landmarks here. That's the pterygopalatine fossa we just talked about. The nasolacrimal duct actually comes from the middle canthus of the eye, and it goes down and drains into the inferior meatus, and you'll see that sometimes as a nice circle. This is the nasopalatine canal, as I mentioned earlier. That's the posterior clinoid process that we saw in our skull base, and the sella is just anterior to that. That's where the pituitary gland lives. Again, important landmarks for the orthodontist. This is our sphenoid sinus. We'll point it out in a moment. This is the clivus, which comes down to the tip of the odontoid process. You kind of want to see, it's almost like a ski slope. You're supposed to be able to slide down that clivus and sit right on top of the odontoid process, which is C2, and this is the arch of C1. These are the lateral and medial pterygoid plates. And then we see the sphenoid sinus on all three of these views here. You see a big black space here on all three of these views here. And look at our little foramen rotundum that we talked about in our previous slides. So let's talk a little bit about the paranasal sinuses, the ethmoid and the sphenoid. Now, unless you're doing big fields of view, you're not going to be looking at the frontal sinus, which is going to be up in here. The ethmoid sinus is basically a series of small cells with lots of septa in here, but it abuts the sphenoid sinus, so that almost in a horizontal plane, with the sphenoid sinus being directly posteriorly to the ethmoid sinus. If you look in the axial view here, you'll see these little cells in here, and then almost this horizontal demarcation here where the ethmoid changes into the sphenoid sinus. And unlike the ethmoid sinus, the sphenoid has very few septa. This has got a little septa in here, but it does usually have a septa that separates it into a right and left sinus. But it's very varied as to the way it appears. And in this particular patient, you can see the left sphenoid sinus is way smaller than the right sphenoid sinus. But all of these sinuses, they're paranasal sinuses, and they're called paranasal because they actually drain into the nose. So in fact, this little opening right in here is the sphenoid ostium that drains into the nose. Let's talk about the maxillary sinus, because for sure, if you're imaging the maxilla, you're going to get the maxillary sinus. When you look at these, you need to compare them side by side. They're not going to always be the same size, but they should be equally pneumatized, which means they should be equally black, because they should be air-filled. We want to be to make sure that they don't have any pathology or any mucosal thickening in them. You want to look for the floor and make sure the floor of the sinus is intact. And then when we look in the axial view, you want to look for this shape. So here's the maxillary sinuses. Obviously, here's the medial and lateral pterygoid plates. This is the nasopharynx here. We're about at the level where the mandible separates into the coronoid process and the condylar neck here. So this is the kind of level we're at in this axial view. What I want you to notice is how you've got this nice little S shape or on the left side and reverse S on the right side. That's the kind of shape that we want to see, and you want to make sure that your margins are all nicely intact. So let's look at the nose. The nose we generally evaluate in the coronal view, but I have all views here. So this is actually the same slice that we just saw with the nose. This is the inferior terminates. And the nose is extremely varied from patient to patient. And the nasal septum, which sits midline or supposed to midline, in this particular patient actually is very close to midline. But that's not the case in many, many patients. Oftentimes the septum is deviated from one side to the other. And these are the inferior turbinates, and they are bigger than the middle turbinates. So here's the inferior turbinates, the middle turbinates, and up here we're catching a little part of the superior turbinates here. So we have inferior, middle, and superior turbinates getting smaller as they progress superiorly, and then some special people have what we call supreme turbinates. And the turbinates are separated from each other by the meatus. So here's the common meatus, here's the middle meatus, here's the inferior meatus here. And I just put this in because this was a research project that I did on nasal airway patency, and just to show you just the incredible variation that there is to the nose. And if we could all have our CBCT scans done, we could probably almost use these like fingerprints. Going back to the maxillary sinus, I want to show you the drainage pathway for the maxillary sinus, because I said that they all drain into the nose. So they usually drain through what's called an ostium. So here's the ostium for the maxillary sinus. This little axis of little bone here is called the uncinate process. The channel the secretions flow through is called the infundibulum. And actually what happens is the secretions come up around here and they actually flow into that middle meatus. So look at this patient. We've got a little bit deviated septum here, turbinates, fairly equal bilaterally, but look how diminutive this right middle turbinate is compared to the left. So when you think about the ostium, it's not exactly taking advantage of gravity. So how do we drain through an ostium that's in a superior position? Well, if you remember your anatomy, the maxillary sinus is lined by the Schneiderian membrane, and the epithelium is the pseudostratified ciliated columna. And the cilia on the end, on those cells, is what moves those secretions up into the ostium, and that's how it drains into the nose. This is the temporomandibular joint. I just quickly want to show you this. We're kind of right at the level of the temporomandibular joint. This is the external auditory meatus. These little guys are the tip of the coronoid process. And here's, as I said, the EAM. The temporomandibular joint on this side looks nice and smooth. It's got a thin corticated border. It looks fairly normal in size and shape. On the right side, though, it's very sclerotic. So if we look at a sagittal view here, you can see our external auditory meatus, glenoid fossa-articular eminence, nice smooth border to the head of the condyle, nicely corticated, nicely positioned. This is a beautiful temporomandibular joint. And on the right side, we see this very, very flattened temporomandibular joint, head of the condyle. And so this was degenerative joint disease on the right. So let's look at some the mandibular branch of the trigeminal nerve, which we said drops out of the skull base through foramen ovale. It gives off the lingual nerve right away, which is sensory to the tongue and floor of the mouth. And then the inferior alveolar nerve enters the mandible proper through the mandibular foramen, which is on the medial aspect of the ramus. It courses through the mandible. Most of that neurovascular bundle exits at the mental foramen, which is about at the between the premolar teeth there, and then some branches go forward to supply the incisor teeth. So what does that look like? Here's an axial view, and we're right at the middle level of the ramus here, so we can see clearly that mandibular foramen right here. We're actually at the level in the maxilla here where we're seeing the nasopalatine foramen here. These little guys are the hamulus, which comes off the medial pterygoid plate. And then here's C2. This is the odontoid process. Sometimes it's known as the dens. And this is the arch of C1. So it comes, the mandibular, the inferior alveolar nerve comes in at the mandibular foramen, courses through the mandible, and basically exits at the mental foramen. When we look at the mental foramen, it looks like these notches in the axial view, as I said, right about the apices of the premolar teeth. If we look at them in the coronal view, you'll see that the canal kind of drops down almost immediately from the mental foramen. Remember, that canal has got to go from the buccal aspect in the mental foramen area and cross over the bone into the medial aspect because it's coming out at the mandibular foramen. This is what the mental foramen looks like. And then anteriorly, we have this little thing called the lingual foramen. And we're not 100% sure what's in there, if it's the terminal branches of the inferior alveolar nerve, or if perhaps there isn't a small branch of the lingual artery that goes in here. But CBCT is showing us all these variations in anatomy. These are very small accessory canals. And this article here, that was done quite a while ago, said that actually there is some viable neurovascular bundle in those particular canals. So anatomical variants, let's look at these. This is probably one of the most common thing that we see. This is a bifurcation of the mandibular canal, where you can see it comes out of the mental foramen here and immediately separates into two canals. And this is a fairly prominent neurovascular bundle right here. You can see that it exits at the in the retromolar trigone area at the retromolar foramen. And it used to be that there was surgeons that were harvesting bone in this area. And if I know that that's potentially the case, I'm always going to be looking for this retromolar foramen or retromolar canal here. Here is one on a parasagittal medical CT slice. So here's the mandibular canal here coming all the way down. But if you look here, you can see this curved accessory canal in here, and it goes from the retromolar trigone area. This has significance if you think about perineural tumor spread, because the most common tumor in this area is a squamous cell carcinoma. Remember, if it hops on that nerve and it can get across the masticator space, where's it going to go? It's going to go back up through foramen ovale. So it has significant implications. We can see accessory canals anteriorly. This is an anterior superior alveolar canal. This is a small field of view. This is the maxillary left canine, number 11, and this large neurovascular channel right here. And you can see in the sagittal view here that it exits on the palate. So we just need to be aware of these accessory canals that may have some impact, particularly if we're placing implants. This was a patient who was referred to evaluate a radiolucency that looked multilocular on a periapical. It went to the endodontist. The endodontist said it's testing vital. I don't see anything wrong, and sent it to me for evaluation of the CBCT. It's kind of hard to see the canal here, but you can see it curves around. I drew it in here for you. And what was happening was it was exiting at two places. So in actual fact, this patient had two mental foramina. And you can imagine that on a 2D periapical image, it kind of looked like it was multilocular. This is just another example from my friend, Dr. Tamimi. And you can see this was actually in the superior cortex of the second mental foramina there. And you can see it was really placed far too facially. And this is a patient who had 3 mental foramina. He was just an overachiever. Variations in the size of the maxillary sinus. Maxillary sinus should normally come down to about the level of the inferior border of the nose. But sometimes we'll just see small maxillary sinuses. This is a healthy sinus. It's just hypoplastic. Sometimes it can be the opposite. It's extremely pneumatized. So you can see this sinus is being pneumatized underneath the nose here. And Brannemark had a classification of this sinus extension into the palate. And it goes from A to E. And again, this is courtesy of my friend Dr. Tamimi from one of the Amesis books here. So if we look at this particular case, we'll see this was probably a Brannemark E classification. It extends all the way underneath the nose. It's like the nose is sitting on a little stalk here. Okay. And one of the things I look for when I'm looking at maxillary sinus is, do we have a prominent neurovascular bundle in the lateral sinus wall, particularly if a patient, if the referring doc is going to be doing a sinus surgery. I just want to point those out to them. This is probably part of the middle superior alveolar neurovascular bundle. So this was the same patient. You can see how extensive the pneumatization is in the palate. It goes basically all the way to the nasopalatine foramen anteriorly. And this was a patient that was referred initially for evaluation because they wanted to put TADs in for orthodontic treatment. And obviously that was not possible. So this can have implications. You do not expect your sinus to become so far anteriorly. So you just need to watch out for that. So the object of using CBCT in surgical guides is to improve your accuracy and placement. The panoramic image here is showing 2 implants on the bottom right. There's a lot of implants here, but we're looking at the 2 implants on the bottom right. And it's really not possible to know in this 2-dimensional image where those implants actually are. So this first, the most posterior one is actually sitting right on top of the mandibular canal here. And then the other one is actually, it missed the mandibular canal, but it missed the bone also altogether. And this is another case courtesy of my friend, Dr. Tamimi. So this is not obviously the outcome that you want to have. So the question is, has it become the standard of care for implants? And what does that actually mean? I mean, it's the degree of care exercised by a reasonably skilled practitioner. But who determines the standard of care? No group really has the legal authority to establish a standard of care. And my good colleague, who's a dentist and an attorney, tells me it's often established in the courtroom by an expert witness. So if you have guidelines from the specialties, that's an important thing to pay attention to. And obviously joint guidelines are better than unilateral guidelines. But the AOMR came out with their position statement in 2012 and basically said, while PANS might be useful in the initial diagnostic phase, it does have significant limitations because we cannot see those buccal and lingual dimension. And plus, it's subject to a lot of positioning errors. And in fact, they found that only 17% of the measurements from the crest to the inferior alveolar canal have errors of plus or minus 1 millimeter. So the rest were more than that. So panoramic radiograph might be good to begin with but it's not really a suitable single imaging source for implant assessment. And their conclusion was that they recommend cross-sectional imaging be used for all dental implant sites, and that CBCT is the imaging method of choice. And that's because we'd rather use CBCT than medical imaging. And obviously the protocols, we talked about them: smallest field of view, lowest dose, diagnostically achievable. And then I also mentioned this post-operatively. If you're looking for osseointegration, rather than doing a cone beam, maybe a periapical is adequate, and sometimes PANS are also adequate because of the beam hardening artifact. So that's the end of my talk. I'm the one in the middle, and so I appreciate you spending some time with me today, and I do believe it is time for me to answer some questions. So let me get out of my presentation mode here, if I can. Let me end my show. There we go. And I'm going to go to our Q&A just to see what questions we have. There we go. All right. Oh, I'm not quite sure what this CBCT method of choice since when. That I'm not quite sure what you mean. I think maybe you're referring to this last slide I was talking. This was an article that was put in 2012. And at that time, there were some machines out there on the market that were doing volumetric imaging. But they, I think they were some like in the state of Connecticut, they had those machines, but they're actually not in market anymore. And so the reason they were saying the CBCT is the imaging modality of choice, as I mentioned, was because it's so much less radiation than medical imaging. I mean, when I first started doing this many years ago, the only way we could get a cross-sectional image was to send the patient to the medical college, and as we saw, that's a much higher radiation dose. So, any guidance on airway space and CBCT? That, you know, I know I didn't get into airway. I mean, this was a very short, it was a lot of information to put into 45-50 minutes. And I potentially will be doing another webinar, maybe on temporomandibular joint. And that's when I usually address any airway issues. I am doing, I know for sure, another one on more in depth on implant assessment and also on endodontic assessment. So we'll see. What else is there in here? Let me see. Does axial view mean looking up from the floor, up or head down? Oh, yes, I apologize. I usually say that when we start to look, we talk about the axial views. So axial views, yes, is just like in dental imaging. When you look at an axial view, the patient's right side is your left side. So yes, it's like you're sitting at the patient's feet and looking up at the patient from the mandible. So yes, so in the axial view, that's exactly what we're looking for. And the same in the coronal view as well. So where a patient's right side is your left side. So thank you for asking that so I could clarify it. What is the radiation dose for CBCT compared to panoramic? Well, as I showed you, it depends on the machine, it depends on the field of view, and it depends on the voxel size. So as I said, the radiation dose for a pan is somewhere between 9 and 25 microsieverts. The average is about 20 microsieverts. Most medium fields of view cone beam CTs are somewhere in the average, maybe between 35 and 60 microsieverts. But you're going to get higher radiation dose if you do a smaller field of view and a high resolution. You just have to have more juice in order to get the information that you need. So it's really hard to say what's the comparison between just generalized CBCT, because it will very much depend on the field of view and the voxel size. Let me look here, what else? Can you go through the TMJ assessment? What features of condylar heads and glenoid fossa do you look for to differentiate normal versus abnormal? Well, that is another webinar, as I mentioned. I mean, we just did not have time to cover every single thing. We didn't have time to cover temporomandibular joint or the airway. So that would be obviously another seminar. Would a patient have to have 2 scans, one pre-op, one post-op for implants? If so, what is the average cost for the patient? Well, that's going to vary from where you are, what situation you're in, whether you're in practice, whether you're in a dental school. Generally speaking, the policy at our school was that we just moved that, yes, you always want a pre-op CBCT implant, CBCT assessment prior to implants. Post-operatively, as I said, sometimes you know, if there are no issues, a periapical or even a panoramic radiograph will do. But oftentimes, if there's some concern about the position or the placement of the implant, really the only way to determine where that implant is to do another CBCT scan. And I know that at our institution, there was a reduced fee if you'd had, if this was a post-operative. And I think it will depend, you know, on where you're at, if you're in a university setting, if you're in private practice. And unfortunately, I have no idea about insurance, so I can't help you with that, except that I'm pretty confident that most insurance plans do not cover CBCT. I think I'm trying to look at the time here, and it is 7 o'clock, so we're coming right up at the end of our webinar. Let me just see if there's anything else that I missed here. What is our responsibility to diagnose pathology outside of the maxilla and mandible? Well, that's a very, very good question, and you have the responsibility. So it's just like any other imaging modality. If you take an X-ray, you have the obligation to read it, which is why I would always advise that you take the smallest field of view you can to get the diagnostic imaging, the information that you need, because that does limit your liability. There is absolutely no reason for you to be imaging the skull base or higher than that if all you need is the mandible for an implant. You should keep it to the area where you feel comfortable. And then if you're not comfortable, then you need to find yourself a friendly oral maxillofacial radiologist who's going to be able to read your scan for you, because you are responsible. Which is why I think if you are doing regularly large fields of view, it probably would be a good idea to have an oral maxillofacial radiologist read the scan for you. Great job. Thank you. Thank you for your compliments, everybody. It was very nice. I appreciate it very much. Are there any radiographic signs you look for with lingual nerve injuries other than a break in the lingual cortex? With lingual nerve injuries, because it's soft tissue, remember, we are not going to be able to see that actual damage to the nerve. So what we're going to be able to have to do is correlate what we see radiographically with our clinical findings. So I've had a couple of instances where patients have been referred because they have symptoms, they have tingling sensation, and then we go and we do a CBCT, and that's frequently when we see the implant has been placed too far lingually. And that's one of the things that I'm very concerned about, because not only is the lingual nerve down there, but it's very vascular, and if you perforate the lingual cortex, that could have serious consequences. You can get significant bleeding and hematoma in the area. So there, obviously, we're not going to be able to see the actual nerve damage, but yes, breaches in the lingual cortex are basically what we look for. I think I've got pretty much everybody. So. Again, I want to thank you. I think we're just about within our time frame. It's 7:03, and I enjoyed presenting to you, and hopefully you'll tune in for the next webinar, which I said is going to be focused more on implants and on endodontic assessment. So thank you very much again to Dexis, and thank you very much for Viva Learning.